Hello, I'm Thomas Lawler, a fourth-year medical student at the University of Kentucky. My case presentation is MRSA septic thrombophlebitis and alcohol withdrawal, an uncommon complication of a common admission. Objectives for this case include reviewing the presentation, diagnosis, and management of CLABSI-related septic thrombophlebitis. We admitted a 60-year-old male with alcohol use disorder for acute alcohol withdrawal and treated him with a benzodiazepine CWA protocol. On hospital day 4, he became febrile to 102.8 degrees Fahrenheit without localizing symptoms. The next day, he developed left forearm pain. On exam, his anterior forearm was erythematous, warm, and tender. Palpable cords were noted near the site of a peripheral IV that had been removed due to infiltration greater than 24 hours before fever onset. Purulent drainage could also be expressed from the site. Ultrasound demonstrated thrombophlebitis of the left cephalic vein as well as a small abscess. Blood cultures grew MRSA. Antibiotics were then de-escalated to IV vancomycin monotherapy. An image of his forearm on the second day of vancomycin therapy is shown here. Given the suppurative nature of the site, the presence of an abscess, and the patient's discomfort level, surgery was consulted to determine whether an incision and drainage was warranted. Ultimately, surgical intervention was not performed. A repeat ultrasound at 72 hours was negative for further thrombus extension. This patient improved with 4 weeks of directed antibiotic therapy, and hospitalization was otherwise uncomplicated. Given clinical improvement in thrombus stability, he did not require anticoagulation or surgical intervention. Discussion. Septic thrombophlebitis is an uncommon CLABSI complication that occurs in approximately 7% of CLABSI cases and is more common with central venous catheters than peripheral catheters. Risk factors include glucocorticoid use, injection drug use, and burns. The most common causative pathogens include Staph aureus, streptococci, and Enterobacteriaceae species. Signs and symptoms include fever, bacteremia, and evidence of infection at the site of thrombophlebitis. Diagnosis is established with ultrasonography demonstrating venous thrombosis along with positive blood cultures. The management algorithm is shown here. Appropriate management includes prompt removal of the catheter in almost every case and an infectious disease consult to determine antibiotic regimen and duration, which should last at least 4 weeks. A repeat ultrasound should be performed 48 to 72 hours after the initial ultrasound to check for thrombus extension. Evidence of persistent signs of infection should also be evaluated. If there is no thrombus extension or persistent signs of infection, then anticoagulation is not indicated and the current antibiotic course should be continued. If there is evidence of either thrombus extension or persistent signs of infection, anticoagulation therapy is indicated. Once anticoagulation therapy is added to the medication regimen, the patient should be evaluated for responsiveness of this regimen. If the patient is responsive, continue the current regimen of antibiotics and anticoagulation. If the patient is not responsive, general surgery should be consulted for possible surgical management, which may include incision and drainage or excision of the affected veins. The patient in this case received an infectious disease consultation as well as a surgical consultation due to the presence of an abscess directly adjacent to the site of thrombophlebitis. No surgical intervention was necessary and he did not require anticoagulation. In conclusion, septic thrombophlebitis is a rare complication of CLABSIs. Given the ubiquitousness of IV catheters in the inpatient setting, early recognition and treatment are critical tools for the internist. Management decisions regarding antibiotic duration, anticoagulation, and surgical consultation require special consideration. Thank you.